The following podcast is part of a certified educational activity titled TROP2-Targeting ADCs in the Forefront, Changing Standards and Best Practices in Triple-Negative Breast Cancer and HR-Positive HER2-Negative Breast Cancer Care. Access the entire activity and complete the post-test at peerview.com/WWQ860. Downloadable slides and practice aids are also available.
Hello and welcome. My name is Garrido-Castro. I'm a breast medical oncologist at Dana-Farber Cancer Institute in Boston, Massachusetts. Today we'll be talking about TROP2-Targeting ADCs at the forefront, changing standards and best practices in triple-negative breast cancer and hormone receptor-positive HER2-negative breast cancer. The goals of today's presentation are to integrate TROP2-targeting ADCs into individualized treatment plans for eligible patients and how that can help optimize TNBC care. We'll also learn about current evidence supporting the use of TROP2-targeting ADCs for hormone receptor-positive HER2-negative breast cancer, and also to master team-based strategies for adverse event monitoring, prophylaxis, and management with TROP2-targeting ADCs to support treatment outcomes and quality of life. So what is the rationale to target TROP2 with antibody-drug conjugates? We know that TROP2 is a calcium signal transducer that is highly expressed in over 90% of triple-negative breast cancers and about 60 to 70% of hormone receptor-positive HER2-negative breast cancers. The way that the TROP2-targeting ADCs work is that the monoclonal antibody binds to the target, TROP2, on the surface of tumor cells. That complex gets internalized into the tumor cell and then metabolized by lysosomal enzymes that release the payload that is bound to the antibody via a cleavable linker. The payload then is released into the cell where it can exert its cytotoxic anti-tumor effects. But for many of these newer generation antibody-drug conjugates, that payload is membrane permeable, meaning that it can exit the cancer cell and enter adjacent tumor cells that may not necessarily express the target of the ADC in the first place. And that is the so-called bystander killing effect of the antibody-drug conjugates. So we'll start first by learning about TROP2-targeting ADC innovations in triple-negative breast cancer. And we'll start with a case. So this is a 42-year-old female diagnosed with a clinical stage 1 triple-negative breast cancer, ER and PR less than 1%, HER2 IHC 0, who underwent breast surgery that revealed a 1.2 centimeter grade 3 triple-negative tumor with negative sentinel lymph nodes. The patient had genetic testing at that time that was negative and received adjuvant chemotherapy with TC followed by radiation. About 3.5 years later, the patient unfortunately presented with metastatic disease, liver and lung metastases, and a liver biopsy was performed that confirmed recurrent triple-negative breast cancer, again, HER2 IHC 0, with a PD-L1 positive result with a combined positive score of 20. The patient received first-line therapy with paclitaxel and pembrolizumab, and after 8 cycles of treatment, developed worsening symptoms, and scans revealed disease progression with new lung and liver lesions. So keep this case in mind, please, as we think about and review the data for the TROP2 ADCs in the second-line setting and beyond for metastatic TNBC. Current NCCN guidelines listed here show different options in the second-line setting for patients with advanced triple-negative breast cancer, including PARP inhibitors for patients who carry germline BRCA1 or 2 mutations, also standard chemotherapy options, but here's also where the current indication for antibody-drug conjugates is listed, with sacituzumab govitecan as the TROP2-targeting ADC, and then trastuzumab deruxtecan, a HER2-targeted ADC, available for the about 40% of patients who have HER2-low triple-negative disease. There are 3 TROP2-targeting ADCs for which we have seen randomized phase 3 data in breast cancer. Sacituzumab govitecan, or SG, datopotamab deruxtecan, or Dato-DXd, and sacituzumab tiromotecan, or Sac-TMT. All 3 of these ADCs bind to TROP2. They all carry a topoisomerase 1 inhibitor payload, though there are differences in the drug-to-antibody ratio and the dosing and schedule of administration of these agents. SG is currently approved by the FDA for pretreated metastatic HR-positive HER2-negative breast cancer and also for pretreated locally advanced or metastatic triple-negative disease. Dato-DXd is currently FDA approved for pretreated hormone receptor positive HER2 negative breast cancer. And Sac-TMT has an indication in China for pretreated metastatic TNBC, and we await data from the phase 3 trials that are being conducted worldwide. For SG, the approval in the pretreated TNBC setting came from the phase 3 ASCENT trial. This was a randomized phase 3 study that compared SG to chemotherapy of physician's choice in patients who had received prior systemic therapy for advanced disease. And the study met its primary endpoint, demonstrating a significant improvement in median PFS in those patients without CNS metastases, who comprise the vast majority of patients enrolled on the study. There was also a statistically significant improvement in median overall survival, as shown on the right. We saw initial data for Dato-DXd in the pretreated setting from a phase 1, the TROPION-PanTumor01 study. Here, in patients with heavily pretreated metastatic TNBC, there was an overall response rate of about 30%, which rose to the 40% range in those patients who had not received a prior topoisomerase 1 inhibitor-based therapy. And finally, we saw results from the phase 3 OptiTROP-Breast01 trial, comparing in a similar patient population to that of ASCENT, Sac-TMT compared to chemotherapy of physician's choice in patients with pretreated metastatic TNBC, also demonstrating a significant improvement in both median progression-free and overall survival, favoring the TROP2 ADC. So if we go back to the case presented initially, a patient with metastatic triple-negative breast cancer who had progressed on paclitaxel plus pembrolizumab, in this second-line setting, what are the options that we could consider? And I think here, given the data that we've seen for TROP2 ADC and improvements in both progression-free and overall survival, favoring TROP2 ADC versus chemotherapy of physician's choice, a TROP2 ADC would be considered a preferred option. And so sacituzumab govitecan here would be a treatment option to discuss with the patient. A few considerations. So what if the patient had different PD-L1 status? So what if the patient had PD-L1 negative recurrent metastatic TNBC? And we'll see in a few minutes the data in the first line setting that have recently been presented for TROP2 ADCs versus chemotherapy, and how the treatment landscape may change for these patients. It's also important to take into consideration comorbidities such as autoimmune disease, whether this is well controlled for exposure to immune checkpoint inhibitors, prior treatment history, also the presence of brain metastases and how this might influence choice of therapy. While the data for TROP2 ADCs in patients with brain metastases are still relatively limited, we're seeing growing evidence supporting that there's also anti-tumor activity with these agents in patients who have CNS disease. Now, shifting from the pretreated to the first-line setting, we know that advanced metastatic triple-negative breast cancer is one of the most aggressive cancer subtypes, and that the overall median 5-year overall survival, that the 5-year overall survival for metastatic TNBC is just around or just over 1 year with standard chemotherapy options. So the question is, could there be a role for TROP2-targeting ADCs in the first-line setting? And with that, we saw at ESMO last year data from several randomized phase 3 trials comparing TROP2 ADC to standard therapy in the first-line setting, including in patients who are not candidates for immune checkpoint inhibitor. ASCENT-03 in the first-line setting for patients not candidates for immunotherapy, randomized participants to receive either sacituzumab govitecan or chemotherapy of physician's choice, which could have been a taxane or carboplatin plus gemcitabine in the first-line setting. Importantly, this study allowed crossover for those patients who were enrolled to the chemotherapy arm, the standard arm, at the time of progression. You can see that this study was powered for progression-free survival and met that primary endpoint with significant improvement in hazard ratio of 0.62. The descriptive overall survival analysis presented is still with immature follow-up with only 37% of events. Importantly, again, there was crossover allowed, and how that might impact the overall survival data remains to be seen. And about 80% of patients who went on to receive subsequent therapy in the control arm of chemotherapy went on to receive sacituzumab govitecan as second-line treatment. The overall response rates were similar between sacituzumab govitecan and standard chemotherapy. It is important to note that this study did allow doublet chemotherapy in the control arm. What it is important to also note is the duration of response, which reached a median of 1 year, with sacituzumab govitecan significantly longer than with chemotherapy in the control arm. So the safety profile seen in ASCENT-03 with sacituzumab govitecan was consistent with previous data in that the more frequent side effects were hematologic toxicity such as neutropenia, including grade 3 or higher neutropenia, and also GI toxicity such as nausea, vomiting, or diarrhea, in addition to alopecia. The other phase 3 trial presented at ESMO in the first-line setting for patients who were not eligible for immune checkpoint inhibition was TROPION-Breast02. This was a study that compared datopotamab deruxtecan to chemotherapy physician's choice in that first-line setting. Here, crossover was not allowed in the control arm at the time of progression. There are no randomized phase 3 data for Dato-DXd in the pretreated metastatic TNBC setting. This study was powered for 2 primary endpoints, overall survival and progression-free survival, and both of these endpoints were met, with a statistically significant improvement in median PFS with a hazard ratio of 0.57, as shown here, and also for median overall survival with a hazard ratio of 0.79 and reaching a median OS of almost 24 months with the TROP2 ADC. The response rates were higher with Dato-DXd compared to chemotherapy physician's choice, though it is important to note that in this study, about 80% of patients in the control arm received single-agent taxane, and there was no option for doublet chemotherapy in this study. The median duration of response was also prolonged with Dato-DXd reaching just over a year compared to standard chemotherapy. The safety profile was also consistent with what has been previously reported for Dato-DXd, with ocular toxicity and mucositis among the most frequent treatment-related adverse events. There also were data presented at ASCO last year, specifically for the combination of SG plus pembrolizumab versus the standard KEYNOTE-355 regimen in the first-line PD-L1 positive setting. These were the data from the ASCENT-04 trial, and in this study, powered for PFS as primary endpoint, you can see that this was also met with a hazard ratio of 0.65. The median overall survival data remain immature, and similar to ASCENT-03, this study allowed crossover at the time of progression to SG in the control arm. The objective response rates were similar between both treatment arms, but the median duration of response was also prolonged with the combination of SG plus immune checkpoint inhibitor. We've also seen data emerging for other TROP2 ADCs in combination with immune checkpoint inhibitor. For example, from the Begonia phase 1/2 trial, there have been data presented for Dato-DXd plus the PD-L1 inhibitor durvalumab in the first-line setting. And here, including both PD-L1 high and low tumors, there was an overall response rate of approximately 80%, and importantly, confirmed responses observed irrespective of PD-L1 status, including in those patients with PD-L1 negative tumors, suggesting that there may be a role for topo-1 inhibitor TROP2 ADC combination with immune checkpoint inhibitors, even in a more immune cold setting. There were also data presented for Sac-TMT in the first-line setting for patients with metastatic TNBC with either PD-L1 positive or negative tumors from a single-arm phase 2 study, the OptiTROP-Breast05 trial. And in this study, there was an overall response rate of about 70% seen in the 41 patients enrolled in this trial, 72% response rate in those patients with PD-L1 negative tumors with Sac-TMT alone. These PFS benefits were also again seen irrespective of PD-L1 expression. The toxicity profile of Sac-TMT in this study was also consistent with prior reports, and of the more frequent adverse events with this TROP2 ADC are hematologic toxicities such as neutropenia and also stomatitis. There are several ongoing trials looking at first-line TROP2-targeting ADCs, including combinations with immune checkpoint inhibitors in patients with PD-L1 negative tumors, several of them listed here. But we've also seen emerging data for TROP2 ADCs in the early stage setting, so moving to the curative setting for patients with early stage localized triple negative tumors. In the phase 2 NeoStar trial, with 4 cycles of sacituzumab govitecan alone or in combination with pembrolizumab, there was a complete pathologic response rate of about 30%. There have also been data from the I-SPY2 study looking at Dato-DXd with and without durvalumab, with similar PCR rates in the 30 to 40% range. And there are several ongoing trials looking at the potential role of TROP2 targeting ADCs for early triple negative breast cancer, in particular in the adjuvant setting for patients who have residual disease after preoperative therapy, who are at higher risk of developing recurrence, and also in the neoadjuvant setting, looking at longer durations of preoperative therapy with combination of TROP2 ADC followed sequentially by additional cytotoxic therapy. Now, shifting towards hormone receptor positive HER2 negative metastatic breast cancer, here there are 2 TROP2 ADCs that are currently approved. So we'll review the data, but first let's start with a case that we can keep in mind as we take a look at the results from these trials and potential treatment options for this patient. So this is a 58-year-old female who was diagnosed with a T2N2 hormone receptor positive HER2 negative IHC0 breast cancer, who underwent upfront surgery followed by adjuvant dose-dense ACT chemotherapy, radiation, and then 4 years of an adjuvant aromatase inhibitor that was discontinued due to side effects. Approximately 7 months later, after discontinuing endocrine therapy, she developed right hip pain, and imaging revealed lytic bone lesions, and staging scans also showed presence of liver metastases. A biopsy of the liver was performed that confirmed recurrent hormone receptor positive and again HER2 IHC0 breast cancer. And for the purposes of this case, let's consider the IHC0 null. The patient underwent germline testing that was negative for a BRCA1 or 2 or PALB2 mutation, and the patient received first-line therapy with fulvestrant plus a CDK4/6 inhibitor, but unfortunately developing progression after 8 months in the bone and new liver lesions, with somatic NGS testing not revealing any actionable targets. The patient went on to then receive cytotoxic therapy, first with capecitabine and then with paclitaxel. And now the disease is unfortunately progressing again, and the liver is rebiopsied and consistent again with hormone receptor positive HER2 IHC null breast cancer. So we'll come back to this case in a minute in this patient who has pre-treated endocrine refractory and also chemotherapy refractory disease. Current NCCN guidelines list recommendations here in the second-line setting and beyond. And here there are several antibody-drug conjugates that are available. Trastuzumab deruxtecan is FDA approved for patients with HER2 low or ultra low hormone receptor positive breast cancer, but there are also in the pre-treated setting 2 TROP2 ADCs available, sacituzumab govitecan and datopotamab deruxtecan, approved for HER2 negative breast cancer that is hormone receptor positive, and that encompasses HER2 low, ultra low, and null tumors. The data for sacituzumab govitecan come from the phase 3 TROPiCS-02 randomized trial for patients with locally advanced unresectable metastatic ER-positive HER2 negative breast cancer who have progressed on prior endocrine therapy and a CDK4/6 inhibitor, a taxane, and also at least 2 but no more than 4 lines of prior chemotherapy in the advanced setting. Patients were randomized to SG versus chemotherapy of physician's choice, and the primary endpoint was progression-free survival, which was met as shown here on the left with a hazard ratio of 0.66. And there was also a statistically significant improvement in median overall survival, just over 3 months improvement with a hazard ratio of 0.79. We can see importantly that the efficacy of SG was observed irrespective of HER2 status, both in HER2 low and HER2 IHC tumors. For Dato-DXd, the supporting data come from the phase 3 TROPION-Breast01 trial, which enrolled patients with advanced hormone receptor positive HER2 negative breast cancer who had received prior endocrine therapy and 1 to 2 prior lines of chemotherapy, so slightly less pretreated patient population than TROPiCS-02. Here, patients were randomized to receive Dato-DXd or chemotherapy physician's choice, and this study had 2 primary endpoints, progression-free survival and overall survival. The PFS endpoint was met, as shown here on the left, with a hazard ratio of 0.63 and 2-month improvement in median PFS. On the right, you can see that the median overall survival was not significantly different between treatment arms. Importantly, the median follow-up was still immature at the time of this analysis. And also, it's important to note that patients in the control arm could have received subsequent ADC as part of standard of therapy, given that there are now multiple ADC options available. And so we do await additional follow-up data from this study and others. For Sac-TMT, the OptiTROP-Breast02 phase 3 trial compared Sac-TMT to investigators' choice of chemotherapy in patients with hormone receptor positive HER2 negative advanced disease who had received 1 to 4 prior lines of chemotherapy, in addition to being endocrine refractory and having received prior CDK4/6 inhibition. And here, the primary endpoint was PFS, which was also met with an approximately 4-month improvement in median progression-free survival, a hazard ratio of 0.35, and also a trend favoring overall survival with Sac-TMT compared to chemotherapy. Finally, at San Antonio last year, just a month ago, we saw the results from the ASCENT-07 randomized phase 3 trial. This is the first phase 3 trial to report data for a TROP2 ADC in an endocrine refractory setting, but after no prior chemotherapy in the advanced setting. So this study enrolled patients who had locally advanced unresectable or metastatic hormone receptor positive HER2 negative breast cancer who had received prior endocrine therapy and no prior cytotoxic chemotherapy for metastatic disease. Patients were randomized to SG or chemotherapy physician's choice, which could have been capecitabine or a taxane, and the primary endpoint was progression-free survival. There was no significant difference in median PFS between treatment arms. The median PFS was 8.3 in both. There was a trend at this immature time point with 27% of events favoring SG versus chemotherapy for overall survival. It is important to note as well that here in the control arm, patients could have received a subsequent ADC following treatment discontinuation on the study. The overall response rate was similar between both treatment arms. The duration of response was slightly longer with SG, reaching a year compared to 9.3 months with chemotherapy. A phase 2 study, SACI-IO HR positive, compared SG with or without pembrolizumab in an endocrine refractory setting and after 0 to 1 prior lines of chemotherapy. So these were also data in a less pretreated setting, exploring the role of the addition of immune checkpoint inhibitor in a more immune cold setting, such as HR positive HER2 negative disease compared to triple negative breast cancer. And here the median progression, the primary endpoint was progression-free survival in the intent to treat patient population. This endpoint was not met. There was no significant improvement in median PFS or in overall survival in the overall patient population. However, there was an interesting signal favoring the combination of SG plus pembrolizumab versus SG alone in the about 40% of patients who had PD-L1 positive tumors, again suggesting that perhaps there could be a role for topo-1 inhibitor-based ADC combinations with IO in more immune cold settings. There was also a trend favoring overall survival for the combination in patients with PD-L1 positive tumors, though the data were immature at this time point, and the overall response rate was similar between both treatment arms. There are ongoing trials exploring the role of TROP2 targeting ADCs also in hormone receptor positive HER2 negative breast cancer, such as the SASHA trial in the post-neoadjuvant therapy setting for high risk HER2 negative breast cancer, and also the TROPION-Breast06 trial, which is a single arm study looking at the activity of Dato-DXd in hormone receptor positive HER2 IHC 0 breast cancer after progression on endocrine therapy and no prior chemotherapy. So more to come on the potential role of TROP2 ADCs in this patient population. What is important to note is that most patients with hormone receptor positive HER2 negative breast cancer have some degree of HER2 expression. So about 60 to 65% of hormone receptor positive HER2 negative breast cancer is what we call HER2 low, which is considered HER2 by immunohistochemistry 1+ or 2+ staining without amplification by ISH. And another 20 to 25% of hormone receptor positive HER2 negative breast cancer has ultra low levels of HER2. And that is faint or incomplete membrane staining in up to 10% of tumor cells. So leaving a relatively small proportion of patients, about 10 to 15%, who have HER2 null tumors, no expression of HER2 on the tumor cells. And this is important because in the HER2 low and ultra low setting for hormone receptor positive breast cancer, there is a HER2 targeting ADC that is available, trastuzumab deruxtecan, that has demonstrated to significantly improve outcomes compared to chemotherapy physician's choice. The first randomized data for T-DXd in HER2 low metastatic breast cancer came from the DESTINY-Breast04 study. This was a randomized phase 3 trial for patients with hormone receptor positive, HER2 low disease who had received prior endocrine therapy and at least one prior line of chemotherapy for advanced disease. Patients were randomized to receive T-DXd or chemotherapy physician's choice, and the study was powered for progression-free survival as the primary endpoint in the hormone receptor positive population, which was about 90% of the patients enrolled on the study. You can see here on the left that primary endpoint was met with a hazard ratio of 0.69, favoring T-DXd compared to chemotherapy. And in an exploratory analysis in about the 10% of patients who had hormone receptor negative HER2 low breast cancer, as shown on the right, in essence, triple negative HER2 low disease, there also the results also favored T-DXd compared to chemotherapy. The DESTINY-Breast06 phase 3 trial took that one step further in the hormone receptor positive setting and explored the activity of T-DXd in patients with hormone receptor positive HER2 low or ultra low tumors who had received prior endocrine therapy but no prior chemotherapy, so a slightly less pretreated setting than DB04. And here patients either received T-DXd or chemotherapy physician's choice, which could have been capecitabine or a taxane, with the primary endpoint being PFS in the HER2 low subgroup of patients. And here that endpoint was met with a median PFS of 13.2 months with T-DXd compared to 8.1 months with chemotherapy physician's choice, a hazard ratio of 0.62. The overall survival data were immature at the time of this analysis. There appear to be no significant differences, though it is important to note that in the control arm, patients may have received an antibody-drug conjugate after participation in the clinical trial, as again, these agents are now available as standard of care in the pretreated setting as well. And an exploratory analysis in those patients with HER2 ultra low tumors, similar benefits were seen favoring T-DXd compared to chemotherapy of physician's choice. So if we go back to the case that we presented initially of a patient who developed recurrent hormone receptor positive HER2 negative breast cancer about 7 months after discontinuing therapy with an adjuvant aromatase inhibitor, treated with fulvestrant plus CDK4/6 inhibition as that first line approach, where somatic NGS testing did not show any actionable alterations. And after progression on fulvestrant CDK4/6 inhibition, the patient went on to receive capecitabine and then paclitaxel, now with disease progression, and another biopsy confirming hormone receptor positive HER2 IHC0 disease. What treatment options are there available for this patient at this time? And here, the TROP2 ADCs, for example, sacituzumab govitecan and Dato-DXd deruxtecan, are options that can be considered. I think it is important to have an informed discussion with the patient about the differences between these TROP2 ADCs in terms of the side effect profile, the primary prophylaxis required with both of these agents, which we will talk about in a minute, and then also the differences in the schedule of administration of these agents. For the purposes of this case, we talked about HER2 IHC0 staining. But what if, for example, the patient had had HER2 low or within that IHC category, ultra low staining confirmed by the pathologist? Then T-DXd would have been an antibody-drug conjugate to consider, where there are robust data for use of T-DXd even in an earlier line setting, and that could have been considered as well. There are important considerations to keep in mind, such as comorbidities, different treatment history that may have impacted choice of systemic therapies as well, presence of CNS metastases we talked about, and also actionable genomic alterations. So, for example, if after progression on fulvestrant CDK4/6 inhibitor, an ESR1 mutation had been identified, or an alteration in the PI3 kinase pathway, that would have opened up other options, such as the oral selective estrogen receptor degraders, or PI3 kinase pathway targeting agents, such as capivasertib or alpelisib. So now we'll discuss a bit some of the practicalities of integrating TROP2 targeting ADCs into routine clinical practice for both triple negative and hormone receptor positive HER2 negative breast cancer, primarily focusing on management of adverse events. We know that the toxicity profiles differ across these TROP2 targeting ADCs. For sacituzumab govitecan, we see primarily hematologic toxicity with neutropenia, including high rates of grade 3 or higher neutropenia, also cases of febrile neutropenia, in addition to GI toxicity such as nausea, vomiting, or diarrhea. In contrast, with Dato-DXd, the rates of hematologic toxicity are lower, but the rates of ocular surface toxicity, stomatitis, oral mucositis are higher. Also, as with all of the deruxtecan-based antibody-drug conjugates, it's very important to monitor for interstitial lung disease or pneumonitis. And then finally, with Sac-TMT, as shown here on the right, we see both hematologic toxicity, such as neutropenia, but also stomatitis with these agents, in addition to nausea and vomiting. It is important to note that for patients who receive sacituzumab govitecan, we know that presence of a homozygous 2828 polymorphism in UGT1A1 is associated with an increased risk of developing toxicity. About 10% of patients are homozygous for this allele and are associated with increased likelihood of developing neutropenia or diarrhea related to topoisomerase 1 inhibitors. In the ASCENT clinical trial, in those patients who received sacituzumab govitecan, those who were homozygous for the allele had higher rates of grade 3 or higher febrile neutropenia, anemia, or diarrhea, though this did not lead to an increased rate of treatment discontinuations. The current guidelines do not endorse routine testing for UGT1A1 for all patients, but we are seeing an increase reporting of UGT1A1 genotyping in somatic NGS panel testing. And so with that in mind, if a patient has a known homozygous polymorphism for UGT1A1, 2828, it is important to keep this in mind and consider dose reductions of sacituzumab govitecan to decrease the risk of developing severe toxicity from this agent. The primate study looked at primary prophylactic strategies for patients with sacituzumab govitecan, specifically with growth factor support and loperamide, with the primary endpoint of this study being the incidence of grade 3 or higher neutropenia and grade 2 or higher diarrhea assessed after 2 treatment cycles. And here, with primary prophylaxis with both of these agents, the rates of toxicity were lower than historical controls from the ASCENT and TROPiCS-02 studies. So when thinking practically about toxicity considerations in patients who are going to start treatment with sacituzumab govitecan, it is important to discuss with patients the high rate of alopecia seen with this agent, fatigue as well, in addition to neutropenia, and to consider use of primary prophylaxis with growth factor support, particularly for those patients who are at high risk of developing severe neutropenia or febrile neutropenia, including those patients of older age who have comorbidities or poor performance status, among other risk factors. It is also important to educate patients on how to manage diarrhea, to promptly report any symptoms, and strategies that one can use, such as loperamide and other antidiarrheals, to help manage this toxicity. If needed, with this agent, despite optimal management with supportive care, dose reductions may also be indicated with treatment. For datopotamab deruxtecan, we've seen that across clinical trials, the rate of ocular surface toxicity is approximately 40 to 50%, and this is primarily dry eye or keratitis. And to try to prevent this ocular surface toxicity, is very important to recommend daily use of artificial tears and to avoid use of contact lenses. Eye assessments with Dato-DXd are also recommended per the current FDA label at the time of initiation of therapy, annually while on treatment, at the end of treatment, and as clinically indicated. For oral mucositis or stomatitis, which occurs in about 60% of patients treated with Dato-DXd, it is very important to recommend primary prophylaxis with a steroid-containing mouthwash to be used at least 4 times per day. Prophylactic cryotherapy, for example, with ice chips, can also be considered. And finally, as with the deruxtecan-based antibody-drug conjugates, it is very important to monitor closely for interstitial lung disease or pneumonitis, and to educate patients on promptly reporting any respiratory symptoms that could develop while on treatment with the DXd ADCs. If a patient develops grade 1 or asymptomatic ILD related to the DXd-based antibody-drug conjugates, based on the timing to resolution of the ILD, it may be possible to re-challenge with the antibody-drug conjugate. But for cases of grade 2 or higher interstitial lung disease, T-DXd or Dato-DXd should be permanently discontinued. And it is very important to educate patients on promptly reporting respiratory symptoms, holding therapy promptly, and initiating diagnostic workup and considering use of steroids if ILD is suspected. So in summary, and some of the key takeaways here today, we have seen the results from several phase 3 trials reported in both triple-negative breast cancer and hormone receptor-positive HER2-negative breast cancer, demonstrating significant improvements in clinical outcomes with the antibody-drug conjugates targeting TROP2 compared to standard chemotherapy, a physician's choice, and standard systemic therapies. There are also several ongoing phase 3 trials that are exploring the role of TROP2 ADCs in less pretreated setting, for example, in the first-line setting for patients with advanced or metastatic disease, but also looking at the potential role of these agents for early-stage breast cancer, including the role of these antibody-drug conjugates as neoadjuvant therapy and as adjuvant treatment for those patients particularly at high risk of developing recurrence, such as those patients with residual disease after preoperative therapy. There are also many unanswered questions related to the potential if and how should antibody-drug conjugates be sequenced now that there are multiple ADCs that are currently available, and much work yet to be done to further understand the mechanisms of response and resistance to these antibody-drug conjugates to help inform optimal combinations, duration, and sequencing of therapy. With that, I would like to thank you for your attention and hope that you found this session helpful.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Gilead Sciences, Incorporated. To access all materials for this activity, visit peerview.com/WWQ860.